a couple of years ago at the Leader Summit for the AOA volunteer meeting.
Yeah,
and one of the things that was really eye-opening to me about that in particular, and you probably don't remember this, but one of the people there, I'll just broadly state that, who I actually respect a lot, and in terms of intersectionality, probably stands with more privilege than I would have to say some of the things that he may have said to you. And I was surprised, and I can't remember the entire conversation, but what I was surprised by was how immediately, like, he gave me a pass, and I think he gave me a pass maybe because he knows me well, but he was pretty hard. I don't know if it was you in particular, but if it was women. Do you recall that conversation? You may not. That's good if you don't. But I think the gist of the conversation was sort of women in the profession, and then I think it was also related to scope in some degree, and but
I have one or two people in my mind.
Yeah.
I've had a number of conversations with a number of people over the years that have stood out. So yeah.
Well, no, it was shocking to me because I, for whatever privilege I may have, I guess I don't have probably the privilege that I have would be that I don't have to think about, like, if I work hard in the profession and I work hard for the profession, then I don't know. I guess I've never had to worry, like, is somebody going to think I'm not going to contribute right? Or just assume that I wouldn't contribute. And that was, to me, I was like, whoa, like, do you know who you're talking to? Like she's got a Harvard Master of Public Health. Like, she cares about the profession and she is moving toward it. I was like, and it was really striking to me, I guess, is my point. And I was like, I'm never going to have an Ivy League degree. I'm pretty sure you're not going to have an Ivy League degree. And so then I guess my point is that was really striking to me. And you said just now that you've had some conversations like that. Mm-hmm. Does it detract from your? Does it ignite your fire? Or does it detract from your desire to kind of be involved? How does that impact you?
Do you remember what comment they made? Like, well, I've had comments.
It's very vague. I mean, in my mind, it's very vague. I recall that it was shocking to me.
I mean, right. A lot of the comments that people have made, not necessarily directed at me.
And it wasn't. It was a generality.
Yeah, it's not usually directed at me specifically, because most of the conversations that I'm engaged in, I mean, certainly, the person that we were talking to didn't necessarily know me, but we were at an AOA volunteer meeting.
Yes.
So
yes.
You could venture to guess that I was involved in the profession.
Exactly.
So, they probably shouldn't make a derogatory comment about, female AOA volunteers. But, a lot of the comments that I hear people make about female ODs is usually about the propensity for female ODs to go into the profession and then take a step back because they want to have babies. And then, it's really just a part-time career choice. And I've heard those types of comments made more and more because one of the projects that I'm working on, that I was on a panel discussion for women in optometry at this past academy. We haven't published the results yet, but we, a few faculty members at NECO and I, one of my co-investigators, Dr. Stacy Lyons, and I we teamed up with Jobson to do a survey. They do sort of their yearly income survey. And we wanted to look at income. Mm-hmm. And to see if there's a wage gap, a gender wage gap. And we hear that talked about a lot, and that's talked about in multiple professions. But when we look at our profession, the data is not really great, and it's all survey based. And, even the survey that we did, it's, it's people just sort of self-select into doing it, but you have to start somewhere. But what we really wanted to do is trying to compare apples to apples.
Yes.
Take the aggregate data. Yes. it's so mixed and it doesn't tell the proper story. And I'm sure you know this, when you are looking at aggregate data, you're not comparing apples to apples. You're comparing different modes of practice, different years of experience, whether you're employed or an owner, different geographic distributions. And so the data is so muddled that you're not telling the appropriate story. And that bothers me as a researcher because it's not factual. And I want to manipulate the data to tell a story that may be advantageous to one group of individuals that I happen to be a part of just because it's advantageous, but not true.
Hello and welcome to Russo Podcast on iCode Media. Today I had a great conversation with Dr. Diane Russo about public health. She has her master's in public health in addition to being an optometrist from Harvard. And so we talked about public health. We talked about women in optometry. We talked about the wage gap within women in optometry. And then we talked about COVID. It was a really fun conversation for me. I hope you enjoy it. As always, be sure to subscribe to the podcast, write a review, and share it with your friends and support those who support us. We've been providing myopia control treatments in our practice for years. If you've been listening to the podcast for a while, CooperVision has received FDA approval of its innovative MiSight one-day contact lens. This will be the cornerstone of a comprehensive myopia management approach to be offered by CooperVision. This daily wear, single-use contact lens is the first and only FDA-approved product clinically proven to slow the progression of myopia when initially prescribed for children 8 to 12 years old and when compared to children in the control group wearing a single-vision one-day contact lens. Check out the show notes for all the specific prescribing details and to get more information about this lens and how you can begin to offer it in your practice. What was her name?
Beth.
And she was on the
Rena.
Yes, Rena was my year.
Okay.
And then Ray, that makes sense. Yes, and okay. Beth was she secretary or vice president or I can't remember the year
something
before.
Like that. Yeah.
Cool.
Oh, it all blends together. Yeah.
I know, it does. It really does.
Yeah.
So, did you guys get to do anything last night? Is Boston pretty much shut down or?
Pretty much. I worked a 12-hour day in clinic yesterday. And so that was the extent of my celebration. But I took off on Wednesday. My husband works for the state, so he had off. So I took off for the day. And so we just celebrated the day early.
Yeah, nice. So then, so tell me about Boston and is it weird? Is it weird to... So they've been pretty much like New York, where things have just been completely locked down for the last 8-9 months.
More or less, yeah. So I live outside Boston. I'm in Framingham, so I'm without traffic, 20 to 25 minutes outside Boston, sort of strictly west. And so I really have only gone into Boston if I'm going to the college, because I'm on faculty at NECO. So if I go there to teach, if I'm teaching a lab, because that's pretty much the only thing we do in person nowadays, I'll just go teach the lab and leave. And so that's pretty much the only time I go to the college nowadays. Or if I go to clinic, so I work at a community health center. So if I go, I'll go to the clinic, see patients, and then leave. So that's pretty much the only time I've been to Boston, with the exception of Sunday, my husband's birthday. We're born 4 days apart. So last Sunday we went into Boston to celebrate, and we went out to dinner. We ate, in the North End, which is like their little Italy outside, for the first time since, I don't know.
That's the first time you've been out?
Well, in Boston.
Okay.
Well, yeah. I mean, pretty much only twice.
Holy cow.
We celebrated our anniversary in September, which is sort of making us sound like we're shut-ins, but
yeah, you are. Yeah.
We leave the house, but we mostly just do takeout and we'll eat in, but we'll go out to walk and stuff like that. But we pretty much haven't gone out socially, really. But yeah, so we really haven't spent much time in Boston socially at all since this all started.
Wow.
So I really don't know very much of what it's like. I mean, people were out, but it was so nice that everyone was just mostly spending time outdoors.
Right.
Yeah.
Yeah. So then, I mean, that's, for us, I think it feels a little less unusual. I talk to my patients about this a lot, is that I'll have, I come home, and it was really great during April, May, June, and then it sort of kind of transitioned back in July. The really great part was that, we were using, and we are now, you're just running around. Like, I'm running kids from one place to the next. So I get home and we're eating dinner for 15 minutes and then we're going our separate ways, And so it was really awesome to, get home, have a cocktail, make a dinner, every night. It was, and I love to cook. So that was awesome. And we just didn't have stuff to do, we just hung out together. And then, we've sort of let, and this happens, you just kind of let everything come back in, and that's what we've done. So for the most part, it shows me that I think, like, our family is pretty well socially distanced. I mean, when I start thinking about, like, what would I normally do, like, I'm pretty much doing the stuff I'd normally do. We're with our kids. The only weird stuff is, like, now that stuff is moving inside, then, basketball games or masked up,
Mm-hmm.
But for the most part, I don't get off of work and then head to the bar. That's not what I do. It's fine. I'm not knocking it. It's something I normally do. So it's not weird to not have that option. And when we go to restaurants, it's not that bad to stick on a mask when we're walking to a table. But you guys can't even eat inside, can you?
You can. I think you can. We haven't. We haven't eaten in a restaurant.
Yeah.
March.
Yeah. Yeah. So I mean, that's so
we
we'll
can,
usually,
I think people can, but we haven't. We've chosen not to.
Yeah. Yeah. I mean, so we, the restaurants we go to are kind of smaller local restaurants, and they're just a lot of room, so we'll eat inside. But it's been so nice that we've also chosen to eat outside a lot. But so it just doesn't feel that weird to me. But when I think about, like, when I've traveled, like when it to Atlanta, I haven't been to, like, the coast since all of the lockdown happened. But Atlanta was really weird. The feeling was really weird. That was back in August, and it was like of Hartford was shut down. Half of the airport was shut down. I don't know. It's just weird. Does that feel like that to you, or is it becoming normal?
Yeah, I mean, I haven't gone anywhere. It feels.
So you are shut in by nature. You're really liking having to Zoom.
It's sounding more and more like it. Yeah, I mean, we haven't got.
You guys have cats?
No, we don't. We don't have pets. We don't have kids. We don't go anywhere. We don't do anything. So it's really made us sort of reassess, like, how we spend our time. We haven't traveled. That is the biggest, I think, difference. We travel usually a lot. We've had to cancel a lot of vacations. That is, I think, the biggest difference. We usually take several vacations a year. We travel out of the country, usually quite a bit. So we haven't been able to do that. And we usually see our families a lot. I think that's usually how we spend most of our time. My husband's family is in Massachusetts. My family is in Connecticut. And so, we've seen my husband's family, but we usually visit outside. So we went on Wednesday. His parents have a puppy. So we went and, like, played with the puppy in the backyard. My family now, it's a little bit more complicated because they're in Connecticut, and now it's no longer classified as a low risk state. So if I travel to Connecticut, I either have to quarantine when I come back or get tested. So it's a little bit more complicated. And especially now, if I come to work, that's now going to get in the way of my ability to work. So now I really can't go see my family without complicating my ability to work. So it's a little bit more complicated. So we've had to FaceTime with my family a little bit more. So yeah, so traveling, it has not been as easy. So because of that, we haven't really gone anywhere.
Wow. Are you doing anything to your, like, for us, one of the things we started working on this summer was just kind of revamping our backyard. And so because that's kind of, and I've talked to like a lot of the contractors that are working for us, and they say that it's like, that's what everybody's doing all across the country. And I didn't even realize it. I wasn't even thinking, oh, well, we're going to do it because that's the place we can spend time with people.
Yeah.
But I think sort of naturally, it's like same thing. We had trips canceled. I hardly ever travel anymore. And so it's like, well, we might as well just enjoy the stuff that we've got. Are you doing any of that kind of stuff?
Yeah, we did stuff. We did stuff around the yard. My husband in the spring, like redid the whole front yard because our lawn was a mess. We did some landscaping. We redid a couple of the rooms in the house. He painted the kitchen. But I feel as though we've exhausted those options.
Yeah.
And
only so much you can do.
Right. And now we're starting to talk about how we need to discover new hobbies because the winter's rolling around. And so, some of those outdoor options are becoming more limited.
Yeah. You guys could learn how to play bridge. Go.
Cribbage. He got a cribbage board.
Did he really?
I'm not kidding you.
You're in for it. Yeah.
So that's next up.
Trivial Pursuit, Yep.
Yeah.
It's awesome.
So
the last time I think you and I saw each other in person, it was probably a couple of years ago at the Leader Summit for the AOA volunteer meeting.
Yeah.
And one of the things that was really eye-opening to me about that in particular, and you probably don't remember this, but one of the people there, I'll just broadly state that, who I actually respect a lot, and in terms of intersectionality, probably stands with more privilege than I would have to say some of the things that he may have said to you. And I was surprised, and I can't remember the entire conversation, but what I was surprised by was how immediately, like he gave me a pass, and I think he gave me a pass maybe because he knows me well, but he was pretty hard. I don't know if it was you in particular, but if it was women. Do you recall that conversation? You may not. That's good if you don't. But I think that the gist of the conversation was sort of women in the profession, and then I think it was also related to scope in some degree, and but
I have one or two people in my mind.
Yeah.
I've had a number of conversations with a number of people over the years that have stood out. So yeah.
Well, no, it was shocking to me because I, for whatever privilege I may have, I guess I don't have probably the privilege that I have would be that I don't have to think about like, if I work hard in the profession and I work hard for the profession, then I don't know. I guess I've never had to worry like, is somebody going to think I'm not going to contribute right, or just assume that I wouldn't contribute. And that was, to me, I was like, whoa, like, do you know who you're talking to? Like she's got a Harvard Master of Public Health. Like she cares about the profession and she is moving toward it. I was like, and it was really striking to me, I guess is my point. And I was like, I'm never going to have an Ivy League degree. Mm-hmm. I'm pretty sure you're not going to have an Ivy League degree. And so then I guess my point is that was really striking to me. And you said just now that you've had some conversations like that. Mm-hmm. Does it detract from your, does it ignite your fire, or does it detract from your desire to kind of be involved? How does that impact you?
Do you remember what comment they made? Like, well, I've had comments. It's
very vague. I mean, in my mind, it's very vague. I recall that it was shocking to me.
I mean, right. A lot of the comments that people have made, not necessarily directed at me.
And it wasn't. It was a generality.
Yeah, it's not usually directed at me specifically, because most of the conversations that I'm engaged in, I mean, certainly, the person that we were talking to didn't necessarily know me, but we were at an AOA volunteer meeting.
Yes.
So
yes.
You could venture to guess that I was involved in the profession.
Exactly.
So, they probably shouldn't make a derogatory comment about, female AOA volunteers. But, a lot of the comments that I hear people make about female ODs is usually about the propensity for female ODs to go into the profession and then take a step back because they want to have babies. And then, it's really just a part-time career choice. And I've heard those types of comments made more and more because one of the projects that I'm working on, that I was on a panel discussion for women in optometry at this past academy. We haven't published the results yet, but we, a few faculty members at NECO and I, one of my co-investigators, Dr. Stacy Lyons, and I we teamed up with Jobson to do a survey. They do sort of their yearly income survey. And we wanted to look at income and to see if there's a wage gap, a gender wage gap. And we hear that talked about a lot, and that's talked about in multiple professions. But when we look at our profession, the data is not really great, and it's all survey based. And, even the survey that we did, it's, it's people just sort of self-select into doing it, but you have to start somewhere. But what we really wanted to do was trying to compare apples to apples.
Yes.
Take the aggregate data, it's so mixed and it doesn't tell the proper story. And I'm sure you know this, when you are looking at aggregate data, you're not comparing apples to apples. You're comparing different modes of practice, different years of experience, whether you're employed or an owner, different geographic distributions. And so the data is so muddled that you're not telling the appropriate story. And that bothers me as a researcher because it's not factual. And I want to manipulate the data to tell a story that may be advantageous to one group of individuals that I happen to be a part of just because it's advantageous, but not true.
Interesting. So here's the thing. I listened to an episode of a podcast when this was a very hot topic in the profession. I would say like a year and a half ago, maybe 2 years ago, before all the other hot topics, right, that we're on to now. And that is exactly what I thought. I thought, look, if it's the case that Diane Russo owns a practice, and sees patients in the same town as Chris Wolf, and sees patients exactly the same, the way you choose to practice is exactly like mine. And I make more than you make, garbage, right? Complete garbage. Like that should not happen. But that is not, that can't be a reality. Like I probably, because I choose to practice and see patients a certain number of days a week, and I do other stuff on the other side, like, then I would assume that a female in my town that owns her practice, that's seeing patients 5 days a week, probably making a lot more money than I am, because if she's billing appropriately, if she's seeing disease patients, if she's, I love that you got onto that idea, because it is not explored and it's not talked about. It's like, oh, wage gap, here you go, 23%. It's like, no. So then what do you do? How do you get to that number to really know, is it less? And what do you do with that information?
It's more complicated. So I think that's what we're wanting to start to tease out, and to really, at least start to branch into two groups. Okay, well, let's start looking at employed ODs and owners, and then parse out male, female ODs. And say, okay, is there a difference? And then parse out how many years have you been in practice? And then let's start looking at the difference in salaries. And so that we still haven't, we're still analyzing the data.
Mm-hmm. What's your sense? What's your sense on the data?
So
like if you talk about employed, so let's say employed ODs.
We haven't started digging into, so what I can say preliminarily is that at least with the employed ODs, that there is less of a difference in employed ODs between males and females when they are first out. For new grads. And so we don't know if we're seeing that initially, because now newer graduating female ODs are now more aware that they need to, like, maybe they know that there is a wage gap, or they hear that there's a wage gap, and they know that they need to negotiate, whereas maybe they previously didn't know. Like when I didn't actually negotiate salaries for previous jobs that I went for, and I was just like, well,
You can negotiate the one you've got now?
no.
Oh, it's time. It's time.
Well, right. So, I mean, so I was not in actually a very good position to negotiate.
Right.
I quit my job before I had another one. And my perspective was, well, this is what I was getting paid. I don't have a job and I need one, and I'm not getting paid less than what I was at with my previous job. So that seems pretty good to me.
Sure. But
that,
you know,
so
do you think women do that more than men? Do you think women take that position more than men? Because that's sort of what I would do. Like I think I'm good at understanding my value, like in a healthcare system, but I'm not that good at negotiating, honestly.
Yeah, I mean, I'm so different now. I mean, this is so with the current position I'm in now. I'm at NECO almost 7 years. I'm so in such a different position now than I was 7 years ago. That I would also say I'm worth a whole lot more now than I was 7 years ago.
Yeah.
So
you hear that, Howard? Are you listening?
Yeah, right. Oh, Howard knows how much so I think aside from just my level of understanding of actual negotiation techniques, I think I understand I have a better sense of what my worth is, quote unquote, and understanding what your negotiating position is. So I didn't really negotiate, quote unquote, for my current position because I didn't really have a very strong negotiating position going into my current position, whereas, I might have been positioned differently. So I think maybe new grads now have perhaps a better understanding. Things are being talked about more than they perhaps have been in the past. So that may be a little bit different. That's just a hypothesis. We are seeing, though, again, preliminarily among practice owners, that there is quite a bit of a difference.
Women make more.
Women make more?
I'm asking.
No.
Oh, they don't?
Vastly different among practice owners, male and female practice owners.
Why do you think that is?
That is the big question.
Because I know, but I think about the women practice owners that I engage with a lot, and I'm like, they're powerhouses. Like, patients like them better than they.
It's a small sample size, right?
Right.
And that's it's a small sample size, but also if you look at, when we looked at practices that had similar gross revenue, there was also a difference in salary.
Do you think they're this is going to probably sound sexist, but
I'd be curious to get your perspective.
No, I'm asking.
Foreign to me from a practice owner perspective.
No, I mean, do you think that they are more nurturing, so they pay their employees more? Do you think that it comes back perhaps that they don't want to negotiate as much because so their cost of goods are higher? I mean, are they reinvesting into the practice, right? Do they view their practice as a place that over time is going to be worth more if they reinvest more? So those would be the kind of questions that I would wonder about. Is there something about, I know we're not supposed to say that, but is there something that women are different than men? Maybe I'm not supposed to say that, but if we assume that they are, and I believe that women are different than men in many better ways, right? And they are way better than us in many ways. And one of those ways might be that they're looking at their practices differently. I mean, I don't know. That's the only thing you could explain with the gross revenue. If their gross revenue is the same or similar, it would have to be one of those things, right?
Right. I mean, these are some of the things that we were talking about, because and we don't have answers, because we're at this point, again, we're still analyzing the data. And these were just some of the very gross metrics that we were looking at. But we're thinking, well, what could possibly be the reason for that?
Could it be
those are some of the things some of the ideas that we were tossing around. Like, what are some of the business reasons that someone can make that they would end up themselves taking home less money, but how could they be distributing those funds amongst their employees or business that they themselves would then end up taking home less money?
Yeah. Could it be that, I mean, other thing, if you're asking me for my opinion, it could also be that they're providing services that cost more to provide, right? Like in general, maybe they're not providing, again, I have no idea, but when I would say, if I were looking at two practices and their exact gross, no matter who owned it, like this is completely agnostic to who owned it. In fact, the things I'm throwing out would be the things I would think about is like, how would you get that net, right? What you're paying yourself, how would you get that higher? It would be the things I said, whether it's a male or female. And then it would also be, all right, well, am I generating, $1 million, we'll just say $1 million. I'm generating $1 million over here in revenue, but I'm seeing all managed vision care plans that requires me to hit that $1 million. I've got to see such a high throughput, right? I've got to see so many patients. I have to have so much staff that all of a sudden what I'm taking home is less, as opposed to maybe I'm providing a ton of medical services and a ton of like additional high value services like scleral lenses, amniotic membranes, ocular surface disease management, with procedures in there, myopia management. Like maybe I'm doing that, right? It doesn't matter if it's a male or female, but if I'm doing all those things, I don't have to see as many patients, right? So I don't have to have as much support staff, and there's less, the patients that I am seeing, the cost to see those patients, even in cost of goods, tends to be lower. So those would be the thoughts I would have about if that actually helps you tease out those differences between males and females.
Thank you for that, because one of our plans is, as we're writing up the manuscript, was to pick the brains of some of our business-minded colleagues as we write up our discussion.
I'll let you know if I find some of them.
Yeah. Because again, part of the discussion is to tease out what some of the reasons could be, because that was part of some of the glaring data that we had noticed in just sort of the preliminary analysis.
Yeah, that's really interesting. None of this is, by the way, what I thought we were going to be talking about, but
Me either. Yeah.
I'm glad we're talking about it, actually.
Yeah.
Do you
a lot of different things I know I had mentioned to you. I'm like, these are the things I'm going to talk about, but I know it gets very scattered for me.
No, I actually prefer not to have a list of things to talk about, actually. I think it makes the conversation a lot more fun for me and hopefully for the people who listen to it. Do you so how, is that just that you picked up on that because you're research minded, or do you think there actually is a public health kind of underlying public health theme to the difference in wage and professional pathways between men and women?
Yeah, so I was a women's studies minor in college. So I've always had an interest in sort of gender dynamics. So that sort of underlies a lot of personal interests. But one of the things that I have realized as I've formally studied public health is that you can make most things about public health if you're creative enough. But certainly workforce dynamics have a role in public health when you talk about workforce demands and meeting the needs of patients. And when we talk about meeting the needs of our patients and thinking about when we talk about the needs of our patients and what our patients look like, and then what our doctors look like, and how we want our doctors to then also look like our patients and reflect the demographic of our patients as well. So then we think about workforce projections and needs that also then relates to our patient needs. So I think, again, stretching to think about how you can make many things public health if you get creative enough. Not that I think workforce demands needs much creativity to make that public health relevant. That is sort of how I view this topic as relevant to the realm of public health.
So I had a conversation, we sort of a little bit skirted around that idea of having doctors who look like their patients. When I talked to Adam Ramsey a couple months ago about this.
I listened to that recently.
Oh, great. Thanks. Did you give me a 5-star review and write a review?
I did not, but I can.
Anyway, so can you elaborate on that a little bit for me? Is like, what does the evidence tell us about patient populations who, and then, about how that impacts their ability to be adherent to prescription treatment plans, follow-up plans, etc.
It is interesting. It can be mixed at times. Some evidence. So certainly there is evidence that supports that patients want to be treated by doctors that look like them, that there is an increased likelihood that they will trust doctors that look like them because they it may be easier for them to build rapport and have confidence in what they're recommending. However, it is interesting that, and I'd have to fact check myself on this because some of this may also be anecdotal, that's not always true. There are certainly instances where patients do have biases against doctors that look like them.
Is that because they're sexist or racist or?
Well, I'm not, and again, this is where you'd have to fact check me because what I've heard on this topic is mostly anecdotal. I don't know the origin of the bias and what it's rooted in, but for example, one of the anecdotes that I have heard is from one of my colleagues where I think it was one of the hospitals in Boston, and one of the patient populations was, I don't remember if it was predominantly Haitian, and the hospital then made it a point to specifically hire a Haitian doctor so that they could care for that patient population. And what they found was that the patients did not want to see the Haitian doctor that they had hired, that they wanted to see the white doctors because they felt that the white doctor was going to provide better care. That was sort of like that what they were, I don't know if it was socialized or like culturally what they were was more acceptable to them, that they did not want to see the Haitian doctor. And so they hadn't really asked the patients what they wanted. They assumed that because the patients were Haitian that they would want to see the Haitian doctor. And that is not actually what they wanted. And again, this is totally anecdotal.
Sure.
But so that's not, you can't always make that assumption, but certainly some at times that is mixed. You can't make that assumption, but there is also evidence that patients do want to see patients that also look like them.
And is that racist or sexist or biased?
That latter part?
Yes.
That is what the patients want, or that we assume that that's what they want?
No, that is what they want.
Well, I guess it depends.
On what?
I guess it depends on why.
Do we know why?
Yeah, I don't know.
Yeah. Yeah. I mean, I don't know either. I mean, it starts to become an interesting question because
it's a good question. It gets at the root of it. I think it depends on you're trying to get to the heart of why. If you're uncomfortable seeing someone that doesn't look like you, I think if you sort of flip it the other way around, I think the question is, why is that? So why are you uncomfortable seeing someone that doesn't look like you? Is it that you have had past experiences, that you have been discriminated against, that you mistrust someone that doesn't look like you, and now you have a preference for someone that does look like you because you feel that you would be more comfortable, that you would be less likely to be discriminated against by seeing someone that does look like you? So I think if you look at it from the other side, so I think it's a great question. I think it just depends on the root
Yeah.
of the issue.
Yeah. I mean, if I'll use me as an example, because I talked about this on the podcast, is I had a massive kidney stone about almost exactly a year ago. And my urologist I was just referred to him by my primary care physician. And when I think about it, like, had my primary care physician referred me to a female urologist, I probably wouldn't have cared that much. But now when I think about it, it's like, I don't know, I probably would prefer to see a male urologist, right? He happened to be from probably South Asia, right? But like, that didn't matter to me. Like, I didn't care about that at all. But I would say, yeah, I'd probably want to see a male urologist. But what's interesting is my wife doesn't want to see a female gynecologist, right? So like, her OBGYNs have always been male. And I've said, well, why don't you, in fact, even one time when a female came in to deliver, who was a partner of the doctor that she was seeing, came in to deliver one of our kids, she was like scheduled to do follow-ups with that other female doctor, and she just didn't want to anymore. And it's a strong preference, I think, but it's a mild preference that she has, which is kind of interesting to me. If I was a woman, I'd probably want a woman OBGYN, right? Based on the experiences that I've had.
Yeah. So I mean, certainly there's sort of, there's generalizable preferences and then individual preferences. And I think any individual will have variable preferences, but I think, in the aggregate, and this is more when we talk about sort of more generalizable workforce demands, I think that's when we think about more, the discussion that you had with Dr. Ramsey about, the 13% promise, the fact that, in optometry schools, we only have 3% of Black students, like, that is where we need to do better. Like, I think, no matter who you talk to, that needs to be improved, because we can do better there. Mm-hmm. I think that is, no matter what any one patient's individual preferences, there's room for growth there. Mm-hmm. So no matter if an individual has a preference one way or another, I think we want to be able to improve the workforce, the distribution of the workforce, so that there is enough workforce distribution so that any one individual's preferences can be met. Mm-hmm. So that even though, let's say your wife has a preference one way or another, or I have a preference one way or another, that I think the ideal that we're striving for is that an individual can have access, which of course, that ideal, we're going to be striving for that forever, but so that an individual can have access to the provider that they're most comfortable with. I think that's the ideal to strive for. Yeah.
Yeah, that's absolutely. I don't think there's any disagreement on that. And I think I do think that some of and this is why I really like the approach that you're taking with a lot of it, is that sometimes I think it can be overly simplified to try to say, we need to have X, right? We need to have X. Like, the reason that we might have, a smaller proportion of X is much more complicated than what we might be realizing. And you probably see this within the studies that you look at within women, or in anything, right? So, or in race or whatever. So then you start going down the path of, and Adam and I don't think, or Dr. Ramsey and I didn't probably even talk about this, but so that's why I really thought it was great. They're starting at colleges where they know they're going to have a larger portion of people in that college that are already high achieving, and they're already succeeding, and they just need to see the profession. And it's also why I love what Adam does even in his local community. He brings kids in from schools and gives them tours and shows them. I mean, that you want to change, that's how you're going to change things, right? Mm-hmm. And so, but then you start getting into like probably the conversation we had about women and money in optometry and payment is that, like, what are the nuances of what people are choosing all along the way? Like, so I don't know. I mean, anyway, it's a lot more complicated, I think. And most people just like the headline.
Yeah. Way more complicated.
Yeah. Yeah.
That is one that is one thing that I have learned and have a much greater appreciation for after studying public health. When I study public health, you have to choose a concentration. And so mine was health policy, which, probably makes sense after all the advocacy work that we did with AOA. And so there's a lot of nuance. With all advocacy work that you do with, legislation, there's a lot of nuance. It's really complicated. And so there's a lot of layers. Nothing is straightforward. And whenever you're having conversations or messaging anything to the public, it's always way more complicated than you could ever imagine that it is. And nuance is extremely complicated to message to the public, to explain. It's really complicated to just fit in a one-liner. I've gained a much greater appreciation for that over time.
How does that impact? What do you think about that complexity within public health and the messaging that you've seen during COVID? Because I would say that it's the same thing. It's like, I think about how are we going to message this new piece of legislation, right? And we toil and we think, okay, well, if this person thinks about it, how are they going to pick that message apart? But the reality is that we're only probably scratching the surface because, there are people in public health that have to know, okay, and we can use masking as an example, right? Like if they would have I'll tell you, I keep saying this, if they would have just in March, as public health officials said, we think masking probably is going to be beneficial, but we also can't have people running all over the place, taking up the supply of masks. And so please, if you need a mask and you feel like you need one, you make one at home, do this thing. We need to preserve these things for our public health, right? If they had done that, do you know what that would do to what we're dealing with now or what we were dealing with for the last, again, whether or not it makes a huge difference, maybe it does, maybe it doesn't. I don't know. I haven't seen a bunch on that, but I'll assume it makes all the difference in the world. The battle that we're having right now is because we just couldn't message it appropriately and treat people like adults. Do you agree with that or no? You don't have to agree with it.
No, I agree. I'm like,
Are there other examples in public health where the same things happen and you're just like, and they use that in class and they're just like, don't do this?
It's, oh God, you like pick the perfect example because I know why they did it.
Yeah.
Because people hoarded toilet paper.
Yes.
It was going out of style. And I understand why they did it. They did it because they wanted to preserve the supply for hospitals, but it totally backfired. And we are, bearing the brunt of that still now. And you add on top of that the culture of the US, which was already going to be, even if they had come out and said that masks were beneficial from the very beginning, there were still going to be a subset of the population that was always going to resist it just because of, the ideals that the country was founded on, that is just entrenched in who we are as a country, that is never going to change. That is the fundamentals of the US.
Yeah.
And that, it is the way it is. And so it's really hard to, it comes with the territory. It's the same thing that we're going to deal with when a vaccine comes out. It's the same thing. And, I get into this discussion with my husband a lot because he's a lawyer. And we talk about this all the time. And we talk about rights and freedoms and all of that. It's like, you have to take the full package. You have to take all the good with all the bad in order to have what you want to have to preserve the country. And so because of that, it makes it complicated to have have messaged anything effectively. So I agree with you that it's like if they had come out in a different way initially, the messaging probably could have been more effective, but you know, it never, there always would have been holdouts. There always would have been people that would resist wearing masks. And if they would have told people early on that the masks were effective, I have no doubt that there would have been people that would have hoarded masks and then the hospitals wouldn't have had them. So it's like, pick your poison. You know, what would you have wanted early on? Would you have wanted the hospitals not to have them, or would you have wanted to fight the battle that we're fighting now later on? You know, you flip the coin and you choose. And so they chose, and now, you know, we're fighting this later on. And pretty much it probably would have been unavoidable. People are going to choose, they're going to do what they're going to do no matter what. I don't see that in all likelihood that this would have been avoidable.
What do you think? Well, yeah, so I think that's interesting too. And it almost, and it begs the question from me, and I have not really heard a good answer. So locally, we are much more of a red state, obviously, than Massachusetts and Nebraska. And I think that comes, there's a lot to that. There's a lot, just like any other things, there's nuance to that. But what I see happening locally in Omaha, and now even in Nebraska as a whole, is that, and nobody's answered this question, is, okay, well, we had a mask mandate in Omaha, right, in July. Our numbers were relatively low in July compared to what they are now. And I said in July, what I said was, if you make a mask mandate, and it's on the podcast. So I said, if you make a mask mandate, what is going to happen in 2 months or 3 months when the numbers go up? It's a completely unfalsifiable proposition. It's either the masks work because we don't have a spike or a peak, or you, citizen, didn't wear the mask like you were supposed to, right? There's no other avenue. And that's exactly what we're seeing now, is that numbers are going up. The mask mandate has held in place. In fact, it's getting more strict now. And the more strict it gets, it seems to be that the higher those numbers go. And so the answer from a public health standpoint, when we see, Nebraska medicine coming out and talking about this, they're saying, well, people are encountering this because they're just having all these gatherings in their homes and in their backyards and this kind of stuff. And I think it's like, well, could it be the case? How would we even know if masks just aren't quite as effective as we think they are, right? Like, maybe they are effective, but we get to pretend right now in my practice, I get to pretend, and I use the word pretend purposefully, that if I have a mask on and my entire staff has a mask on and every single patient has a mask on, that I'm actually less likely to get infected from a patient, or vice versa, when I'm sitting at a slit lamp 1 foot away from them for a minute, than I am if I'm outside 5 feet from somebody else with no mask on, right? I get to pretend that that's true, and I'm just not convinced it is, right? I'm completely like accepting, not because I don't think I will get sick. I actually think I'm gonna get sick, and not because I don't think I could get sick really bad. I think I actually could, right? But I'm just accepting that that's kind of the nature of life a little bit, but I get to pretend like that mask, that patient could have never got infected from me, and I could have never got infected from them, because when I go to the hospital and they find out, oh, we had a backyard get together around our fire pit and we were within 5 feet of our neighbors, and that must have been where I got sick, right? Like, that this doesn't make a lot of sense to me. But that's the game we get to play.
Yeah, it's not, the thing is, there's still a lot that they don't understand. And the distancing, I talk about this with one of my colleagues, Dr. Gary Chu, a lot, often, because, and he and I were just saying this maybe like last week when we talked, the distancing, the 6 feet distancing, like that came from like the most recent SARS epidemic that we learned from, and the next epidemic or pandemic that we have, hopefully not another pandemic, but it will probably be another maybe 9 feet, so we learn from each outbreak. And so we don't know that the 6 feet is like that magic number. And so, so there isn't really knowing that 6 feet is really protective. And the masks aren't foolproof. And it, depends on what mask you're wearing and how old the mask is. And how long have you been wearing it? And is it full of condensation? So there's all these X factors that affect the efficacy. And so we don't really know when people are contracting it or where. And, we've been dealing with this as these types of questions as well. So I think no matter where you are, what state you're in, or if there's a mask mandate and whatnot, everyone's expecting the cases to go up as it gets cold because people are going to be spending more and more time indoors. And, whether you're masked or not, the reality is people are not going to be masked fully indoors. Whether you're, and is everyone going to be spending time only amongst their immediate family indoors? No, you're going to be with extended family. You're going to be with friends. Even if you're in a restaurant, germs move around.
Yep.
There is some amount of airborne spread. That is evidence of that is still somewhat mixed, even though there's.
Sorry to interrupt, but is that because of droplets are so small, or it's actually airborne?
Yeah, so there's the respiratory droplets that is clearer cut, but there is mixed discussion and evidence about actual airborne spread that is not the respiratory droplets, but they do find it sort of in air ducts that there's more discussion about how much of it is actually spread through airborne and not just the respiratory droplets that you would get if you're within the 6 feet of someone. So there's still a lot that is not totally understood. And so because it's sort of to speak to what you're exactly saying, that just because there's a mask mandate in place, that it's not foolproof.
Right.
And we know that. And so I think that's why the public health officials continue to just reinforce. It's like, well, control what you can control, because there's so many X factors that we know we can't control. So it's like, we know that you can put the mask on your face. We know you can control how far your body is from another human. We know you can control.
Some people can. You don't have 8 kids that can't control how to other people.
Yes, kids are a whole different story. Yes, certainly. I mean, my brother, he has 2 kids as well, and so I certainly feel for anyone with children right now.
But so do you think
that's why they reinforce those behaviors, because there is so much that is out of our control.
Is there an approach to public health then, even as we're having this conversation, where, in my opinion, in Nebraska, a mandate is probably not the best thing, right? Like again, and I had this conversation with somebody that was illuminating to me recently that, my perspective is, just tell us, like, show me the evidence, like, show me why it's important. Tell me the same things that you're saying right now. Tell me, like, really, you should do all these things that we're talking about in the mandate, but like, just don't make it a mandate. Like, just inform me. Like, I understand that there are risky behaviors that I could do any day, that aren't mandatory for me not to do them, right? They're not illegal, but I don't do them. And so and I don't do them because it's not something that I want to engage in, because I understand the risk. So why, from a public health standpoint, is there consideration where you can say, look, we can mandate all we want, but maybe the better option is to, educate people as best we can, just like if we were mandating something, but just educate them on the stuff that you and I are talking about.
So optimistic, Chris.
Well, that's exactly what the person I said the other day was. They said some people, Chris, just need to be told what to do. And I thought, whoa.
It's so I think I certainly wouldn't probably put it that way. especially because no one likes to be told what to do. And when you put it that way, like my spite sensor goes up. Like if you immediately tell anybody, like, just do it.
Wear the effing mask.
Yeah. Oh, it's like,
oh, that's like the worst.
Like, no, even if like I philosophically agree with you, I'm immediately going to be like, nope, just because you told me, like, I can't do it now, like I do it,
So there's got to be a lot of that, right? Like, so that could be
so
part
like,
of what
principle, as soon as you tell me I have to do it, there are people that are going to resist, and that's what you want to avoid. And so you sort of want to appeal to people's better nature. And so I mean, I agree with the wearing of the masks, and there's the science behind it. And even if it's not, 100%, there is evidence behind it. The masks do work, and to whatever extent that they do work, it is safer to wear the mask than not to wear it. And so it's just that mandate piece that gets people, and it's unfortunate that that's the piece that sort of divides us. And yeah.
So what's the better approach then? I guess because that, I guess it's probably my worldview of like, tell people what's good, tell people what they should be doing based on the evidence of what you're seeing, and then let them decide what they. Now I understand that there's other people that they could infect, and et cetera, that don't have a choice in that. But I don't know. I just tend to see, and maybe it's optimistic, I just tend to see that, so I guess there's those two dichotomies, and how do you address that in an effective way from a public health standpoint?
Yeah, I mean, this is the challenge. I mean, this is the challenge to living here in the US, right? I mean, and this is the challenge to being to trying to implement any type of public health initiative, because public health by its nature requires collective action. And by its nature, our culture in the US is individualistic. And so it bumps up against our individualistic nature to act collectively. But that's the challenge with the masks. In order for the masks to work effectively, you need really that collective action. You need everyone, or the vast majority of people, to be wearing their masks. And so that's the major challenge. How do you get everyone on board and appeal to everyone's better nature without making them? How do you like ask really nicely, but then when someone says no, ask even nicer? It's just, I don't have an answer. I mean, and the answer that some states have implemented is the mandate. But that's the challenge. And there is no one size fits all. There's no great answer. And that's why the states have, all handled it differently. Some have chosen to implement the mandate, some have chosen not to. And that's why we're having such a heterogeneous response. And that's why we have all different COVID rates all across the country, because the response has been so varied.
Yeah. How do we get out of this?
Oh, well, time and a vaccine. I mean, but even that is a gross oversimplification, because again, even if we have a vaccine, which it looks like we may, then it has to be manufactured, it has to be distributed, and people have to take it. And vaccines work kind of in the same way that masks work, which means enough people have to take it that we have herd immunity, which we've been fighting sort of the same battle on the vaccine front that we have on the mask front, where you have to have enough people that take it for that collective action.
Are you going to take it?
Yeah. If
you take it right away?
If Fauci takes it, I'll take it.
If Fauci does?
Mm-hmm.
Really? Why Fauci?
Because I trust Fauci.
So that's very interesting to me. So what if there was another Fauci? I don't know that there is, but what if there's another Fauci that says because if you have you really, so HIV and AIDS has always been fascinating to me, and so I have a lecture on it that has been chosen twice. In fact, I get to do it tomorrow for South Carolina, and when you look at what happened with HIV and AIDS, they rushed through AZT. They put through a trial, and there was like 19 people that, first of all, they didn't let them take anything else. So they couldn't get treated for other things like Bactrim for their pneumocystic pneumonia. So they put them all in this trial. They couldn't have any other treatments that they knew were helpful to those patients. And they gave 19 of them AZT, 19 of them nothing, right? Or placebo. And it was like just radically different. Like these people all died, these people did okay. And so they like rushed it through, right? And then they found out later on that they shouldn't have rushed it through. It wasn't probably the right dose. It wasn't that much of effective treatment, and et cetera, et cetera. So I look at that and I think, I won't blame Fauci for either, but Fauci does happen to be a common denominator in that. And I look at that and I'm like, well, this vaccination was rushed through. So what if there's another guy that, other people would say, this guy's pretty reasonable. He understands infectious disease, not Chris Wolf, but he understands infectious disease. And I think what he's saying makes sense. So I don't know, maybe I'll wait. Like, is that the right decision? Because you trust Fauci. What if I trust somebody else? But you don't trust that guy. And so now we're at this impasse where it's become like masks. I think that there's very close to that. Patients on the left and patients on the right tell me they're not going to take the vaccine because of Trump wants it, or because Fauci wants it. It's like, is it a bigger problem?
I mean, that's why I said, even if and when a vaccine comes out, this is not going to be over. But
have we set a precedent for the next pandemic, or for even just the next like viral respiratory disease that's novel? I mean, I don't know. I guess I'm sort of maybe not off topic, but we've really set a precedent, in my opinion, to do this exact same thing again.
In what way?
Well, I mean, let's say you have if you go back to look at SARS and what was the M1?
H1N1?
No. Yeah. Well, you look at any of them. SARS and was it MERS?
I think so.
Yeah. And so like, had we done, if one of those things come back, right? Or like a new thing comes, like, SARS-CoV-3, right? Then are we going to do the same thing? Even if it may not be necessary, where we test asymptomatic patients, we do, like, that seems to me like, could we have set a precedence from a public health standpoint that is going to follow us forever?
Perhaps. I think,
can we afford that? Can we actually like do that long term?
I think, since we have gone through this, I mean, we're still going through it, but we will have learned in the postmortem of this, we will have learned a lot. There will be a copious amount of studies that come out of this. And my hope and my assumption, I think a decent assumption, is that we will have learned a lot coming out of this, and that we will be then much better prepared. I mean, certainly depending on, this was a novel virus that they weren't prepared for because they didn't understand it. That posed, unique challenges. But I think as far as handling the pandemic and the contact tracing and all of that, I think my hope is that we'd be much better prepared to handle that moving forward.
Yeah.
I mean, I think part of the piece that made this particularly unique than in the past is how much more technology we have now than we've had in the past, and how much more access to information and misinformation we have access to.
Yeah.
And that is much more unique. And I think that's made things better, but also a lot worse.
Well, I think it's because, a lot of people, and I'm skeptical of every single thing I read. It's about, in my opinion, it's not even so much about whether I'm right or left or libertarian or, liberal, right, or progressive. It's more about like clicking, right? Like it's more about, I'm going to present you a headline that you're going to click on. And if I read into the entire article, I'll probably get the entire story and I'll get it accurately. But that headline is going to be catered to Diane Russo's political beliefs. But that same company might actually have one that's going to cater to my beliefs. And they actually know, if they present it differently, which one. And they're going to present me one and present you one. And then we both get a click on it. So we don't really have it. And so then it leads me to just not trust anything. So then I'm searching for like, well, what do I trust and who do I trust and how do I know who I can trust? And I think that's really a huge problem.
Yeah, it's scary. I think also even the scientific journals right now are moving. I mean, they're not going through the peer-reviewed process. They're putting things out quickly. And, they'll say that this is, I don't know, the disclaimer that they're giving you, but it's not peer reviewed. It's like ahead of the process. And so it'll be even more interesting to see the postmortem of all this when everything really has been thoroughly vetted, to see what the results are and what the journals say and what the results are. Because all the journals that, we would normally go to, New England Journal of Medicine, the Lancet, like they're just rushing to get things out as quickly as possible, to share the information as quickly as possible, that it's not being as thoroughly vetted as it normally would be. So they'll put something out and then they have to retract it or correct it. And so it's hard to keep up, but it's also, puts that question mark on, is this the most reliable information? Is it all correct? Because it hasn't gone through the rigors of the peer review process that it normally would. And so that is also a little bit scary, because the normal scholarly journals that we would go to, even that is not as rigorous as it normally would be. And it's understandable, because they're trying to keep up with and churn out the information that they have as they are receiving it. So, it's some crazy times that we're living in, but it's scarier when you think about how reliant we are on the sources of our information, and how unreliable that really is nowadays.
I'm going to leave it at that, Diane. I'm going to be respectful of your time.
That uplifting point.
No, this is a super fun conversation. I'm really glad we had it, and we got to do this more often.
Great to catch up. Thanks for having me.
Yeah, thanks for being on.